Hello and welcome everyone for another show of MEDtalkx being broadcasted live on Pendle Community Radio was 103.1 FM, as well as our usual social media channels such as YouTube and Facebook. Please do subscribe, share the links, and spread the word. We do cover a range of health and well-being topics, but today we will be covering musculoskeletal health, as well as opportunities and challenges that that area poses. So just a couple of questions, well, a couple of prompts really. If you want to get in touch, we will try to answer any questions posed our way. The WhatsApp number is 07522 723 455, and the studio number is 01282 723 455. Over to you, Fahim.
Thanks, Mehran, and good evening and a warm welcome to the whole audience and our two lovely guests tonight. I'm really pleased to be able to welcome Mr. Naveed Ahmed. He's a graduate of Bangalore University in India, where he did his undergraduate training in the year 2000. Then he started his career in the UK in orthopedics at Stoke, and currently he's doing his orthopedic training based at Cardiff University Hospital, which is one of the busiest hospitals in the UK. So a warm welcome to you, Naveed.
Thank you.
And also we have Dr. Amir Akhtar. Amir is a GP. And in addition to that, he has many hats. He's also an osteopath as well. He qualified at Sheffield University back in 2007 and did his osteopathy qualification from the London College of Osteopathic Medicine in 2017. And he also has a private clinic called Spiro Clinic as well, based in the Northwest. Warm welcome to you, Amir.
Thank you. Thanks for having me.
Great. Okay, so if I can start with you, Naveed, please, if that's okay. Naveed, obviously, for those people listening tonight, we're talking about orthopedics and musculoskeletal medicine. Can you give them a bit of an overview as to what your day-to-day life is as an orthopedic surgeon?
Sure. My specialty includes both trauma, which is fractures, and elective surgery, which is arthroplasty, where you do joint replacement surgery. So basically the trauma involves taking care of patients with fractures when they come in. Like, for example, if somebody has had an accident and he comes to accident emergency and he's initially treated with painkillers and he's put in a plaster, has an x-ray, and my job involves looking after the initial management of the patient, admitting the patient to the relevant specialty, and also making sure that he's ready for the operation most of the time the next day. So it also involves medication for the patient, and also in a broad sense, taking care of the patient post-operatively, liaising with the physiotherapy, and finally discharging the patient. And we do follow the patients up after the surgery, post-operatively in the clinic. On the elective side, which is the arthroplasty side, we see the patient in the clinic or initially, and then we put them through a physiotherapy program if it's feasible, and sometimes they go directly towards surgical management, as they would have gone through the physiotherapy program already, and finally they end up having the surgery in the next few months, and we follow them up after the surgery with x-rays. That's the overview of what we do.
Thank you so much, Naveed. And Amir, obviously you're a GP and a special interest in orthopedics. Can you tell us what made you interested in orthopedics and a typical working week for you?
Yeah, so my working week is sort of split between my clinic and general practice. So, for example, Monday and Tuesday are spent at my private clinic in Burnley, where we see patients. We sort of do physical therapy, manual therapy, some chiropractic type work, also joint injections, some back injections as well, dealing with common musculoskeletal conditions. And that's combined with, we're in Manchester on Thursdays, and on Wednesdays and Fridays, I still continue some of my work as well. So it's like a
Right.
50-50 split. I still do general practice, and we combine that with doing musculoskeletal work in the remainder of the week.
Great. So Naveed, if I turn to you, obviously with
Yeah.
the current COVID pandemic,
Yeah.
I want to try and focus on a couple of areas. One is about triaging and workflow in the trauma setting, and how have theatre services had to adapt to the current situation?
So this has been a sea change, really. First of all, all the elective surgery has stopped since end of March, and there has basically no joint replacement surgery has happened in our hospital ever since. On the other hand, our trauma surgery has to go on because patients have falls and then you have to look after them. That hasn't changed in terms of providing treatment, but has changed in terms of how we do it. So when the patient comes in, they are assessed to have if they are corona positive or not, and they are split into relevant wards where there is a suspected coronavirus patient is put into a suspected ward, and then there's a clean ward and a dirty ward, and we do have clean and dirty theaters. For coronavirus positive patients we have a different theater, and for negative patients we have a different theater. And obviously for every patient, irrespective of they have corona positive or not, we have to use your PPEs, which involves using respiratory type masks and goggles, and obviously double gloves and clean PPEs, and obviously it takes the length of time the surgery happens is also increased, and therefore the number of operations we can do in a certain amount of time has reduced due to that. Um, on the whole, we are able to cope as long as PPE is available, and we are able to do the surgeries. But the time taken is much more in every patient.
Great. So, but in terms of outpatient follow-up, Naveed, has that had to be done differently? Because I think we all can probably relate to a lot of things being done via telephone, but obviously when someone undergoes trauma, and a huge part of that is rehabilitation, is actually assessing someone's functioning. Has that had to change, or is it still just using COVID secure methods?
Most of the patients have to be seen on the in the hospital, but there are certain conditions where you have a tiny fracture, for example, the foot fracture or a hand fracture, which has been treated correctly in accident emergency. Those patients can be given advice on the phone, and that's what we have been doing. So we've been giving general advice, looking at the X-rays and liaising with the patients. And most patients have been very forthcoming, and they do understand the problems, and they would like to avoid coming to hospital, and therefore it has reduced the number of patients we have to see. Yeah, but the ones we have to see, we do have to use PPE, mask and gloves and um, and extra precautions when they come in. They have to have their temperature checked by a nurse, and they have to use alcohol gel. Yeah, and children are not allowed most of the time.
And Amir, that's a big jug of water you have in there. You threw me with that. In terms of obviously your work, can you tell me a little bit about how you've had to manage with the COVID pandemic and how that's changed how you work?
Yeah, sure. I mean, we were closed for 4 months or 3 months. We only opened about 5 weeks ago. So it sort of got to the point where I had patients who were banging on the door, literally speaking, wanting joint injections, wanting physical therapy, because a lot of physiotherapy has now turned to video consultations. So we've sort of gone with an alternative model where we've slowly started to get patients back in with full, obviously wearing PPE, visors, face masks, making sure the patient wears a face mask as well. Not as rigorous anywhere as rigorous as what's going on in hospitals, obviously, but then again, our procedures are not as intense either. So we've adapted in that way, where patients come in, they're screened at the door. At the same time, there's a good gap between patients. There's only one allowed in the waiting room. We've got air purifiers in as well, which we've imported from, funnily enough, China. And we've sort of adapted that way, and we're just seeing how things go, really. I don't think anyone's got the absolute answers. Most of the physiotherapy clinics in Burnley have actually been closed. I think they're just reopening now. So we were probably one of the first clinics in the Northwest to start doing hands-on treatment and seeing patients face to face.
And if there's someone in the audience, obviously you're based in the Northwest, so you're quite readily accessible for many of our listeners and viewers. They wanted to come and see you. You mentioned steroid injections. Can you tell maybe the listeners as to when is a steroid injection an appropriate treatment therapy?
Yeah, I mean, steroid injection, again, it has to be weighed up. Not every problem can be solved with a steroid injection. And steroid injections were actually completely sort of banned for 3 months during the COVID crisis, because there was a theoretical risk of, there was a study done which showed a potential theoretical risk of increased chance of getting COVID. It wasn't a rigorous study. And there's been lots of conflicting research around that, where they've then said dexamethasone sort of helps COVID. So no one has the true answers, and a joint statement was released around about 5-6 weeks ago when we reopened, saying steroid injections in the right circumstances, where a patient's quality of life was really, was really going downhill. And if they needed a steroid injection, it might be knee arthritis, it might be, certain forms of arthritis. Usually that's where we tend to do a steroid injection. We sometimes do it for things like frozen shoulder, where it works really well, for wrist arthritis. So there's a few conditions. We don't always just use steroid. There's other things we use as well, like PRP, which is platelet-rich plasma. We use something called Prolotherapy, and we use a host of stuff. So steroid injections, again, if we feel it's useful, we'll do it, but that's only after a careful assessment of the patient. So not everyone will suit a cortisone injection, but in the right patient, it can make a dramatic effect to their pain.
And Naveed, if I focus onto you, what are the kind of simple steps that you can perhaps share with the listeners and viewers about pain management? I guess there's one aspect being the conservative element, as well as just the tablet form of pain management. What can you inform them?
Because the conditions are so variable, I think the best way would be to focus on, say, for example, knee arthritis, which is the most common sort of arthritis we see. For that, we normally use physiotherapy and mainstay management. For example, if a patient has pain, we start with pharmacological medications like paracetamol, cocodamol, and ibuprofen, which is codeine and anti-inflammatory medications. These medications used properly can prolong the need for arthroplasty, which is joint replacement surgery, at a short time. So therefore, we have to involve patients in terms of their mentally, and also they need to be told about exercise, the importance of exercise, physiotherapy, exercise, and also weight loss, which is quite crucial in reducing the joint arthritis pain. Obviously, like Amir's mentioned, physiotherapy with steroid injections used properly could manage arthritis for years and reduce the need for arthroplasty surgery. And there are a subset of patients who cannot have a joint replacement because it's a health risk, because it's major surgery, because of their general comorbid conditions like heart conditions or lung conditions, they can't have the surgery, and these are the patients who benefit with the most with steroid and physiotherapy, weight loss, this sort of. But we expect all patients who are going through the pathway towards arthroplasty to expect to be actively involved with physio and gone through the process of trying medications first before joint arthroplasty. Yeah, that's how we manage the pain.
Great. So those individuals, I guess, who continue, unfortunately, with pain because they haven't been able to, exercise on a regular basis, both from a kind of government perspective as well as from a health conscious perspective. What's the exit strategy? Because there must be a waiting list that's ever increasing. So how have you in your region thought about addressing that need?
Obviously, the lists are increasing, and the waiting times. They started about 6 months was like the gold standard. Nowadays, it's gone well up to 2 years of waiting time, and obviously, the number of theaters have to be increased, and the number of surgeons who can manage to do arthroplasty have to be increased. And in general sense, the amount of money coming into arthroplasty, which is joint replacement surgery, has to increase time bound. There are strategies taken by all NHS trusts, and we are guided by NICE and Royal College of Surgeons, and they come up with guidelines to improve this. Like, for example, the strategy just released for diabetes only yesterday talk about giving them a diet as part of diet medication instead of medications, milk drinks and things like that, which improves their general health to reduce the incidence of diabetes. And these are sort of strategies which have involved. We do have a musculoskeletal referral pathway where all patients have to be seen by the physiotherapist first after the GP referral. So they go through the pathway of physiotherapy. Those who fail are the ones who actually get referred to us, so that the number of patients actually are streamlined to a large extent. Yeah.
Amir, we've had a question come in from a viewer. Does Dr. Amir provide guided steroid injections? I'm guessing that's ultrasound guided. And if so, what's the advantage of that for a frozen shoulder?
Yeah, that's a good question. Yeah, the procedures we do are done under ultrasound guidance. It's really a more accurate needle placement, really. So research has shown when you're using ultrasound guidance to sort of guide your needle, then you will get more accurate needle placement and hopefully better results. Again, it depends on which joints you're doing. In the right hands, quite often, you don't always need ultrasound guidance. But generally speaking, especially if you're injecting certain bursae, certain joints or certain areas like plantar fasciitis, areas like that, then yeah, ultrasound guidance has its place. And it's widely used now. It's adopted by, hospitals and the high quality sort of orthopedic clinics out there. Yeah.
And touching on something that Naveed spoke about in terms of these pathways where they go to a physiotherapist first before maybe a surgeon or something. You're probably aware of this, Amir. Can you maybe tell the audience a little bit about when is the right imaging modality, for instance, MRI scan or ultrasound, for the different joints? And we may have possible patients in the audience who are wondering, well, should I get an MRI scan for this? Should I get an ultrasound, or is it just physio? Can you maybe just explain a bit of that? Actually murkiness around this imaging and when it's appropriate for what?
Absolutely. I mean, completely, again, it's very much joint dependent. Ultrasound is really good depending on the actual pathology. So if let's take a simple example, because I wouldn't want to go too broad with this, but if you've got something like a rotator cuff tear, quite often you'll get excellent you'll get an excellent sort of image with ultrasound, which will be comparable to an MRI scan. However, if there's pathology within the actual shoulder joint, in that sort of situation, you might be better off getting an MRI scan. And don't forget X-ray itself. X-ray is often overlooked. People, like to sort of go with the high-tech imaging, but X-ray can be can give you a lot of information that at times even gets missed by an MRI scan. So it really depends on the problem you have, the joint being assessed, and the actual pathology. Don't forget, in each joint, you can have several things going on at once, and it completely depends on what you're looking for. So if you're looking for a rotator cuff muscle tear in the shoulder, yeah, you could use ultrasound and get quite good sort of results with using that imaging modality. Again, MRI, very useful, but you wouldn't actively be able to test your rotator cuff muscles with an MRI scan. However, an MRI scan will be very good for checking for something like a labral tear within the actual shoulder. Similar thing with things like hip pathology. An X-ray would be your first choice, assessing something like arthritis. So you'd go for an X-ray. Following that, you might go for an MRI. Similar with knee, if you're looking at structures within the knee, then an MRI tends to be the best modality. You don't tend to use ultrasound on the knee as much. So it really depends on the structure you're testing, whether it's a joint or it's a muscle. So it's a very difficult it's very difficult to say a certain modality would be preferable to another. You'd really have to be sat in front of an experienced clinician and have a proper examination, and from there that would guide where you go next.
Amir, in your earlier answer, you talked about providing prolotherapy, which I guess is also a form of provocation therapy, which is used to toughen up ligaments and tendons.
That's right.
What's your feeling on the outcomes of it? Because the jury is kind of still out there in terms of efficacy, isn't it? And I don't know whether is it the way it's done and the compounds used, or is it just generally it really depends on the clinician?
It really does depend on the clinician and the sort of the compounds are being used. So, for example, prolotherapy really came over to the UK from America, and it was sort of pioneered here by some physicians in London. Prolotherapy is widely used now, both in the UK and abroad, and the solutions used are different as well. So you can use sort of spinal prolotherapy, you can use something called P2G, and then in the peripheral joints, knee joints, ankle joints, in those things, we tend to use something glucose solution. And again, that varies in the concentrations used. I'm a fan of it. Not everyone is a fan of it, and research doesn't always back results up. But sort of anecdotally, with some of the patients that have had prolotherapy, some have had excellent results. Again, we use that in combination with physiotherapy as well. So a lot of things we do, it's a multidisciplinary approach. So an injection itself won't always work. You sometimes do need the physical therapy to go with it as well. And
Naveed, if I focus onto you, the rate of osteoporosis are increasing. I guess there's with the role of calcium and vitamin D. Is this very much common practice in terms of outpatient clinic? And do you have any more thoughts of what roles it plays, especially given the current COVID situation?
Sure. So we do class fractures as osteoporotic related, especially hip fractures in elderly are classed as osteoporotic fractures, irrespective of if you see osteoporosis or osteopenia, which is reduced bone density on X-ray, and also patients with distal radius fracture, which is the wrist fracture, which is the most common fracture we see in the clinic. And these two fractures are classed as osteoporotic fractures, and we have guidelines from MHRA and also from NICE regarding management of these patients. So as part of the post-operative care of these patients, all of them are referred to on our orthogeriatric team in the hospital for hip fractures, which involves being seen by an elderly care consultant who specializes in especially taking care of patients with osteoporosis. We do have a long list of medications which can be used, and most common, like you mentioned, is calcium and vitamin D, which is prescribed on all patients as long as they do not have certain conditions like a kidney disease, where you have to be careful about. And sometimes the patient has malignancy. Again, there are some contraindications, but certainly on all patients we use calcium and vitamin D. There are other medications, for example, alendronate, which is a special medication given once a week, which helps in building the bone density. Although it does have its side effects, like you do get acute gastritis related to that. Those are the things which are tested by the orthogeriatric team. With regards to distal radius fracture, when a patient comes with a wrist fracture, which is the most common fracture, we refer the patient for what's called a bone density scan, where the scan is done to look at the density of bone, and we do have WHO guidelines for that. So depending on that results, the most of the time the GP is responsible for follow-up of these patients for the results with regards to whether you need to start alendronate or just calcium and vitamin D. So it's a very complex sort of treatment. Obviously, patient have to be encouraged with diet. Diet plays a role. Milk. Some patients avoid milk, and those are the sort of patients who have risk factors. And some people cannot have associated jejunitis or some gastrointestinal problems where the absorption is an issue, and those are the things which are have to be looked at in terms of how you administer the vitamin D or calcium. Yeah.
Naveed, obviously, sorry, yeah, go on, Matt.
No, I was just impressed with the range of beverages Amir has at the moment. So, I'm just complimenting that. Yeah, go on, over to you.
Naveed, obviously your interest is hip and knee surgery, so I want to focus now on that. Hip surgery and replacement of hips is a very common thing, especially people older than age 60. And there's many things that lead up to a hip operation. Can you give us a bit of guidance as to some of the things leading up to a hip operation and things that patients should know about after a hip operation, common things?
Yeah, so the patient, once he's been diagnosed to have osteoarthritis of the hip and has tried out all the physiotherapy and analgesics, and most patients don't like to take medications like anti-inflammatory for the rest of their lives, and they do fall into an age group between 60 to 70 years, which is the best kind of time to do the surgery. So a patient, when he's gone through all the non-operative managements, we tend to send them to a specialist nurse who has a clinic where they go through all the different pathways. So the patient is explained about his actual surgery itself and what he can expect after the surgery. And also we do blood tests, including their heart ECG, and we look at his general health, his chest X-ray, making sure that he's ready for surgery, and his prolonged anesthesia, which may be up to 1.5 hours on the table. So the patient has to pass all the tests. Otherwise, he's classed as high risk, which may delay his surgery because he needs an ITU bed, and these are the things which are difficult to manage. So we do have specialist centers for high risk patients where we need to have a high dependency bed available prior to surgery. But on a general sense, these patients go through this pathway. They understand. Nowadays we have websites specific for that, which explain the actual consent process. What's called Consent Plus, which explains the the nature of the surgery and the risk factors, including because there's mortality as well, which some patients don't seem to understand. They think, oh, you come, you have your surgery, and you go home walking. Unfortunately, it's not the case when you look at the nitty-gritty of the situation, and therefore we have to explain the side effects and complications of surgery. And also we talk about MRSA, which is methicillin-resistant Staph aureus, which is a common problem in hospital, which is drug-resistant Staph aureus, which is a bacteria, and these are again tested for every patient prior to surgery. And if somebody has got it, has to have it cleared. It can be a skin commensal. It can stay in the axilla and the groin. And these are the patients who have their surgeries delayed. And some patients, believe it or not, some patients are newly diagnosed diabetes because of the testing, because they've never been tested. Some are newly blood pressure. They've never had their blood pressure checked, and they have their medication started, and therefore it's very important to go into pre-assessment, what we call, prior to surgery. And it's a very finite sort of well classed process. And then patients then have the surgery. Some of them even have physiotherapy exercises taught prior to the operation, so that they actually understand the whole process. Yeah.
Excellent. And Naveed, moving forward onto the knee as well, obviously you've mentioned mortality, something to think about for hip surgery, and perhaps the audience are more familiar with the knee surgery from maybe hearing about it from footballers having it and so on. Can you tell us a bit about which sort of types of people get the knee surgery, and maybe a little bit about the different types? There's things like arthroscopies and as well as knee replacements, and can you tell a little bit about the differences?
Sure. So for example, as what's called sports injuries, where we class them as, those are the sort of patients with anterior cruciate ligament or meniscal injury or cartilage damage, or what we call osteochondral lesions. These are the patients who benefit with arthroscopic surgery and ligament reconstruction, which is ACL, which is very common. These are patients, orthopedics to some extent is age-based. You got to be young to be able to go through this surgery. But if somebody has got a well-established osteoarthritis, which is very common in the age group between 55 to 70, these are patients who benefit with arthroplasty surgery, which is joint replacement surgery, where we use metal and polyethylene, which is a specialized plastic in the knee joint. We do have different types in that. We have nowadays what's called a uni-compartment knee replacement, where you don't have to replace the whole knee. We only take off the damaged area, which is most commonly the medial compartment, and we replace that. We also can do patella kneecap surgery specifically. We don't have to do the rest of the knee. So yeah, there's a wide variety of surgeries available for the knee joint. And is ever increasing. The knee arthritis is more common now than hip.
And I guess it'll be kind of to your kind of responsibility as well as your teams to actually go through all the options available to the patient, isn't it? Including getting the right consent, the risk and complications. I want to focus onto Amir, back pain and its prevalence during COVID. Has that led to any changes in management? I guess because some of the time people approach primary care physician like yourself, Amir, and expecting a X-ray because they've been suffering from back pain. What kind of strategies and management techniques would you recommend? Because you're also, I understand, through Spiral Clinic, there's role of osteopath as well as chiropractor.
So the sort of approach I use for back pain is really the osteopathic approach, we have something called the concept of somatic dysfunction, where it's a bit different to physiotherapy, really. We use palpatory skills to try and identify where the problem lies. A lot of the time, I find with the back pain, it can happen when the patient is either been too active or not active enough. In COVID, we probably had the opposite, where people were just confined to their homes. The problem was exacerbated because a lot of the even the NHS physio clinics were video only, so you can't really assess the back digitally. You can run through a few tests that a patient can do, but there's nothing beats getting your hands on the actual patient, getting a feel of the area that that's sort of painful or isn't moving as it should be, and identifying the source of the pain that way. So we use a very much a hands-on approach in doing that. That's obviously not always possible with the NHS. A lot of the time, patients are given sorts of exercises. We try and focus very much on an examination that tends to last around about 45 minutes, taking a very careful history. And because it's a private clinic, we have that luxury. We tend to go through quite a few things. I wouldn't say the prevalence increased, but probably the way it was dealt with was much more challenging than before, because obviously physios were very much restricted in what they could do. A lot of the things we're seeing now are the things that have always been around, something we call degenerative lower back disease, sciatica, prolapsed disc. Sometimes it's just postural issues. Sometimes it's muscle spasms due to the way we work. Sometimes it might be a physical job, a very manual job. Sometimes it may be very much an office-based job. So what helps is actually getting our hands on the patient, trying to find where the area of the back where the problem lies, and treating it in different ways. We can use chiropractic methods, which can really help. We can use osteopathic methods, which are a combination of physiotherapy and manual medicine. We can give rehabilitation exercises, and sometimes when need be, we can also give injections. So I guess we have a few tools available at our disposal, which is a bit different to how it's normally approached, because obviously a lot of physiotherapists can't inject. Being medically qualified, I'm able to inject. So in that sense, we're at a bit of an advantage as well from that point of view. So yeah, probably it was probably the actual COVID pandemic probably just sent people loopy, sat at home, not able to do anything. Boris Johnson kept sort of altering the exercise advice as well. So I think a combination of that probably didn't maybe increase things, but we sort of didn't really feel that. I think it was just the way it was dealt with. Even now, a lot of physiotherapies are still doing video calls, and it's very difficult to assess a lot of MSK conditions by video. It's a real challenge. You can probably manage some of them, and you can do exercise prescription, give patients a sheet, give them a program to follow. But there's nothing that beats actual manual therapy, which is getting your hands on the patient, watching them move, trying to use your palpation skills, getting to the joint, getting a good feel of the actual area that's under pressure. And you can pick up a lot just by sort of examining with your hands. So yeah, it's been interesting anyway, some of the things we've sort of picked up. And obviously with NHS under a lot of pressure now, you've got orthopedic waiting lists are getting longer. The similar pressures are being felt by the MSK service and physiotherapy service as well. So patients are getting a bit frustrated, but at the same time, we have to be absolutely, we have to be as safe as we can be in this pandemic, especially when we're not sure what's going on in the future either with this talk of a potential second wave. So safety, comes before everything else, and the NHS has had to adapt there as well.
Yeah, as you mentioned, coronavirus, and I guess living within those kind of restrictions that it poses has been difficult for so many people, regardless of age, regardless of ethnicity, regardless of gender. So I fully agree with your premise that it has been difficult, and it has meant their presentations has changed somewhat. We do have to be mindful that pain is also a common presentation for mental health disturbance, so it's always important to kind of rule that out. We are getting a few questions flying through. There is a question from a listener, Nelson, asking, what is the assessment process to diagnose if someone is suffering from musculoskeletal problems? Now, I might ask you, Amir, for that, and I guess that maybe with a caveat of, if let's say if someone's in an accident or someone's had a work-related injury, and they need ongoing assessment.
Yeah, I mean, if this is from an MSK point of view, because don't forget, if someone's been in a sort of road accident or something, there's many pathways and many sort of clinics that deal with this sort of problem. I can only tell you what happens at Spiro, where we try and take a really thorough history and do quite a thorough examination. So that would last about, I think it would last about even up to half an hour, which is not something that you would always get. It's quite hands-on. And from that, we sort of make either a plan where we might need further investigations, we might need imaging, or we might be able to go straight into treatment at the same appointment. Again, depending on what the problem is. So as an example, if someone's got a shoulder problem and they've had it a while, because we have our own ultrasound scanners, we might be able to scan the shoulder, take a history, do an examination, scan the shoulder, and we might even be able to inject all in the same appointment, which may last about an hour. That obviously is a luxury that you can't always get. Sometimes in the NHS, you would be referred to an MSK service. They'll do the initial assessment. They might do some physio exercises for the patient to go away and have. If they don't get better, they might be referred further for a scan. So there's obviously a time element involved, but that's because the NHS is dealing with thousands and thousands of patients. Ours is more of a private clinic where we deal with smaller numbers, and that's why we have that luxury of probably being able to do something a bit more detailed. So yeah, it's almost like a one-stop shop. We try and deal with things, and if we can't do it in one session, we try and keep it minimal, maybe maximum 2 sessions. And that way the patient can just go away and sort of get on with it, and we might just follow them up later. So that's where the private side is more of a time-saving strategy rather than you waiting and waiting. You might get in quicker and get things done faster, but obviously there's a cost to that as well. Whereas the NHS, you won't be paying anything, and you can get very good treatment on the NHS as well. It's just obviously, there is a weight associated with that.
Naveed, there's another question come in. I want to give you an opportunity to answer questions as well. Okay. The question is on MSK Health. Is there any link with family genetics? So obviously with many medical conditions, there is a genetic predisposition or even an association. Is there anything that you can tell the listeners and viewers about if an older member of the family has suffered with an MSK problem? Does that increase your chance, just from what you've experienced or observed?
Yeah, the osteoarthritis picture, which is the most common arthritis we see, this has got a large genetic background. For example, the Caucasian population is higher risk of osteoarthritis. Having said that, for example, if somebody has got arthritis in one knee, may not develop arthritis in the other knee. So there is a lot of genetic amalgamation, which is very complex and has been still studied. And it's not a very clear cut, like, for example, if the father has arthritis, the son will have it. It is not the case, but the risk on general, like a population, if you look at a cohort of patients with a similar sort of background, they tend to have arthritis in the families. With regards to rheumatoid arthritis, which is a less common type and which is an inflammatory arthritis, is you do have a higher risk in the family. But the condition is multifactorial. It can be associated with other conditions, wherein like overweight, smoking, alcohol. These do add to the picture of arthritis. But the mainstay of the background why somebody ends up having arthritis is genetic. Yeah.
And in terms of trauma, Naveed, obviously that's one of your specialities and interests. And I remember reading back in April when the COVID pandemic was, say, at its peak, and there was some information on an opinion piece in the BMA, and an orthopedic registrar was saying, be careful about trampolining and so on. And, just after dinner time is when kids have accidents, when the parents aren't maybe as conscious at looking after them and so on. Do you have any tips and advice now in avoiding trauma, or is it a normal part and parcel of growing up? And will we never be able to reduce the danger of trauma?
Yeah, trauma is ever increasing. So you have to balance life, to be honest. The idea of children playing more video games and staying home is probably not what I would recommend. Having said that, you do have to take safety measures when you have like trampoline, and it's very common problem we see. Especially common in children with have no protection when they're trampolining, and also if two children are trampolining at the same time, and those are the sort of times where we see them fall off, and they come with horrendous fractures, and they have to be treated. The idea of reducing the number of trauma is important, especially in a situation like this, because this will avoid you having to come to a hospital and having to go through surgery. And one of the places where you can actually catch coronavirus is a hospital. So it's best to avoid all that. And therefore, in a way, it does make sense to reduce the risk of having to come into hospital.
I must say bless you to the individual that's been sneezing repeatedly for the past 5 minutes. Yeah, he's must have been quite a difficult position he or she finds himself in. So I'm going to try and bring you in, Amir. And in terms of training, and we'll try to touch this on your specialist training as well, Naveed. What has that meant for the trainees, given the current circumstances? And what, in terms of primary care in general for the future?
Sorry, do you mean the training pathways, or sort of
the training? Because I guess we've talked quite extensively about musculoskeletal pain, but in terms of actually those delivering that kind of support, how much support do they get? Do they have to work differently? Because obviously, given the current pandemic.
Yeah, undoubtedly. I mean, it's the people who are training in this area. It's going to have a detrimental effect, because the amount of cases they're going to see of MSK conditions, or say orthopedic conditions, it's going to go down, because the number of people coming through the doors are a lot less with all the measures they've got going on. A lot of courses, a lot of sort of MSK development courses, things that you do within your career as well, just to keep up to date or further develop your practice. Those courses are pretty much on hold at the moment. So training in the MSK area has really suffered, because these courses have been suspended. Patients aren't really being brought in, because a lot of the things you learn are on live patients. For example, ultrasound scanning, those courses are on hold. So it's had a negative impact on the actual training itself. The same with people who are doing the run through on the sports and medicine and exercise program. The number of patients they're going to get exposure to is a lot less than it would have been before, purely because of hospital protocols and the patients coming through, because MSK essentially is more of an elective speciality. It's not an emergency. 95% of the time it's something that can wait. And those cases are being put right on the back burner at the moment. So you're simply not seeing what you would be seeing otherwise. To learn, to reflect, to learn, to further progress your development. So it's not good. And we can only hope things get better, really, because career-wise, people are probably it's gonna hamper development, at least for the next, I would say, 6 to 12 months.
And Naveed, if I pose that question to you, in terms of the impact of COVID for orthopedic trainees, the exposure, as well as the different ways that patients are presenting, because one of the key aspects is workforce preservation as well as development, isn't it, to provide that ongoing support? I don't know what your thoughts are on that.
Yeah, it has affected pretty much our training to a large extent. Now that I'm part of this training process, there are some hospitals which are not at all operating, um, and some of them are only operating trauma to minimal level. So therefore, the amount of cases we are actually seeing for our training needs are minimized, and therefore it may be that this may affect our length of training and also the amount of training we actually get with regards to specialization is going to have a direct impact on that. And also, if you look at what our junior doctors who come into orthopedics as part of their rotation, they're also feeling the pinch, and they have been asked to do what's called a COVID sort of rota, where they're just looking after patients with in different wards rather than having to go to clinics and theaters. And essentially, it's a very difficult time. Yeah, it's a very on the long run, we really cannot say what's around the corner, to be honest.
And Naveed, I know from your biography you've worked in different parts of the world. Obviously, you were in India, Stoke, Cardiff. Can you tell us about a different case mix that you might see in different parts of the world? Is there any difference with geography, or bones just bones wherever you are in the world?
Yeah, the trauma and how you treat it is different. And the trauma here, we do see a lot of high speed um, accidents with multiple injuries. And for example, in India, we used to see low energy trauma, and delayed presentation is very common in India. And we used to see a lot of secondary problems, like patients have been treated inappropriately in another place and they're being transferred over, and malnutrition and which is very common in India. And obviously, poverty brings its own problems. So yeah, there is definitely a different case mix. Here we tend to see either uh, common fractures, which are like hip fractures in elderly, which is very common. And then on the other spectrum, we do see high energy impact injuries where you can have head injury, neck, a spine injury, and multiple bone fractures, which need ITU management. So, yeah, those are the sort of patients which differ at the moment.
Okay, and back to you, Amir. Obviously, you're dual qualified. You're an osteopath and a doctor. Just for the audience, can you tell us the difference between what does an osteopath, chiropractor, doctor do, and like when should someone go see all of that? I can see Naveed smiling just there. And really, what do the medical profession consider of these professions?
Yeah, I mean, with an osteopath, there's a massive crossover, between osteopathy, chiropractic, and physiotherapists. Because what happens is once you qualify, you tend to go down a certain route where you sort of subspecialize within the area as well. So it's primarily when you do osteopathy, you're concerned with you do a lot of your training on the spine itself, on back pain, back problems. So you develop a real awareness of your palpatory skills. And you have a crossover with chiropractic, because the founder of chiropractic was a student of the founder of osteopathy. So in chiropractic, what you do is you primarily do a lot of manipulations. So if there's a muscle spasm, if there's an area that you can feel isn't very mobile, you'll sometimes do a manipulation just to sort of get it moving, and that can often work wonders for a patient, especially when they've been in pain for months. So that's essentially with osteopathy and chiropractic. That's what it actually is. Osteopathy itself has various techniques within it: mobilization, stretching the muscle, doing soft tissue work, identifying trigger points. And that's very similar to what you'll find again in chiropractic and some physiotherapy. So we tend to use a combination of methods in all three disciplines. You have a massive crossover. It completely depends on the actual individual you're going to. So a physio may actually work like a chiropractor, and some physios do. And a chiropractor may actually work like a physiotherapist without actually labeling himself that. Primarily, we're sort of, we deal with, joint pain, back pain. Osteopathy itself is probably 80% of your workload is back pain, and identifying problems with palpation. The way a joint moves when it's restricted, and just through that alone, you can sort of identify problems that many times you wouldn't. I mean, as a GP, I would have really struggled without having these skills. So it's more of an extra string to your bow, and obviously we offer lots of options before a patient may need surgery, for example. I mean, no matter what you do, there's going to be times when a patient will need surgery. No matter how much physiotherapy they have, no matter how much chiropractic or whatever they have, they'll still need an operation. So we try and identify those patients that we might be able to solve things without an operation, and try our best with them. And sometimes that works. But again, it's not a replacement for surgery or anything like that. Often, when a patient needs surgery, they need surgery. What we try and do is sometimes with joint injections, things like that, that can sometimes delay surgery. A patient may want to go, doesn't want a knee replacement in the next 3 months. They just want to try and preserve the knee for a while. We can then do certain treatments around the knee joint on the muscles, and that brings them a lot of relief and gives them a bit more time. They can go away and have that holiday. They can come back, and then they're listed for their operation. So there's sort of many angles to it, and it all depends on what you've sort of subspecialized in further along the path.
Great, thank you for that, Amir. I know time is dwindling very rapidly. As customary to our usual radio show, we do ask for 3 tips for the listeners. So Naveed, if I focus onto you, what tips would you give to the viewers and listeners about how to make sure that they live a good quality of life in terms of their musculoskeletal health? Sure.
So joint problems are very common, and the best way to deal with joint is a combination of medication and exercise. The most important thing is when the patient has a lot of pain, he's reluctant to move, and he then comes to wanting surgery. But if you have a combination of exercise with analgesia, wherein the patient takes analgesics and then a few hours later is able to do a bit of exercise, and a combination of this can actually reduce the risk of having to have surgery. And that was my first tip. And my second tip would be to diet control is very important for hip and knee osteoarthritis. If once you reduce your weight, the chances of having surgery and also even a recovery after surgery is much better. These are my 2 tips. Thanks.
Over to you, Amir. Naveed's given 2.
Yeah, I mean, I can only echo what Dr. Naveed said, and the other thing I would say is get moving, go for walks, enjoy nature, live with passion and fire. That's the only other thing I would add to that.
Perfectly put. But I'd just like to say thank you to both Naveed and Amir for sharing their Tuesday evening. Fahim, do you want to say a little bit more about next week?
Yeah, absolutely. So next week, we're hopefully talking about fostering adoption, which is an important topic. Obviously, we just started a bit later now, 8:15, just for people to remember, 8:15 to 9:15. I want to thank both of our guests, Amir and Naveed, for spending time. Amir, do you want to do a quick plug as to your clinic for the actual details for anyone who wants to listen before we go?
Yeah, by all means. I mean, it's spiroclinic.co.uk. We have a website, and we've got 2 locations now. One in Manchester, in city centre Manchester, and we've got one in Burnley. So yeah, feel free. If you're struggling and you find you're not getting anywhere, just a bit frustrated, by all means, come along and see us, and we'll see if we can help. Yeah, you've got nothing to lose. except a bit of your bank balance.
Except money. Yeah. Okay. Thank you so much to both of you for spending the evening with us. It's been really illuminating. We've had a lot of questions during the whole evening, and I've learned a lot as well, Naveed. So I'm going to look up Consent Plus this evening. So I was actually busy trying to find that out, and it did look very interesting. So thank you. As ever, it's been educational for us as well as the viewers and listeners, I'm sure. Many thanks and good evening, everyone.
Okay. Take care, everyone.
Sorry.